Chapter thoroughly explores sleep disturbances, primary sleep disorders, and parasomnias. Various treatment issues and options are presented and discussed. Sleep disturbances are frequently cited problems by mental health patients. While many of these patients also have a comorbid physical condition that interfere with their quality of sleep. Some clients experience sleep disturbances related to substance use or abuse. There has been some research that has established that those with sleep disorders are at an increased risk for developing hypertension and suffering cardiovascular morbidity and mortality. The most common sleep complaints made by mental health clients involve initial insomnia, which is difficulty falling asleep, or intermittent awakening throughout the night, which is like middle insomnia. Some clients may fall asleep normally, but awaken very early in the morning with difficulty falling back to sleep. This is called terminal insomnia. When we look at the sleep stages, there are 5 stages of sleep. Stages 1 and 2, which is considered or called theta waves, during this time, this is light sleep. During this light sleep, if a client's name is called out during this stage, they will probably awaken without feeling groggy. The next stage, which is 3 and 4, in which delta waves occur, this is where slow wave patterns and deep sleep occurs. It's necessary to awaken him or her, and that person would probably be groggy during these stages of sleep. The final stage, which is stage 5 of the sleep stages, is rapid eye movement or REM. This is about 25% of the night and is characterized by both theta and delta type activity that resembles the wave patterns seen while awake. Most dreams occur during this stage. If a client is sleep deprived, they may demonstrate additional time spent in stages 3 and 4 and REM during their next sleep period, which is called the REM rebound phenomenon. Serotonin is necessary to maintain adequate sleep, especially in stages 1 through 4. Norepinephrine is necessary for REM sleep. Now, this is not surprising because depressed clients with lower levels of serotonin and norepinephrine usually experience poor quality when it comes to sleeping. As a clinician, when we have a client that comes in with sleep disorders or just problem sleeping, these are some things that we need to determine. If the sleep disorder is caused by a medical condition, psychiatric, or substance abuse, so of course, based on our assessment and our intake and getting history and family history and current conditions, the last time they've gone for a physical, all these things will play a part in helping us determine the possible cause of the sleep disorder. It's also, as mentioned, collect adequate history information, inquire about daytime sleepiness, memory, concentration concerns, depression. Is there an increase in accidents, and not necessarily car accidents, that they're just making a lot of mistakes, and an impaired job functioning? Is it getting in the way of them completing duties and tasks at work, and sometimes duties and tasks in other areas? If so, it might be necessary to refer them to a neurological or sleep specialist. As mentioned, sometimes sleep disorders are caused by other conditions. So we need to take into consideration is that when we find that a person may have initial insomnia, this might be a possible indicator that they might also have an underlying anxiety disorder. If they're experiencing middle insomnia, it might be an indicator of possible affective disorder. And keep in mind, I am saying possible because it's a possibility, because might truly be a sleep disorder. But these are just things that we would keep in mind while we are providing therapy to our client. Types of sleep disorders and treatments. We look at obstructive sleep apnea. With OSA, the client is unable to keep airways open during sleep, and the airways narrow or collapse, leading to gasping or awaking throughout the night. Now, what's helpful is that if a person has sleep apnea, they are giving a continuous positive airway pressure machine, which keeps the airways open and they do not face the problem of basically their inability to breathe in the middle of sleeping. Sleep bruxism is a technical term for basically teeth grinding while a person is asleep. It is common amongst children, but it can also be seen in adults, and usually a mouth guard is given by a doctor, or more likely a dentist, to assist with that. We have sleepwalking and night terrors, which is another sleep disorder, and clients outgrow this condition. Benzodiazepines are not recommended for children or substance abusers. Narcolepsy. When we look at narcolepsy, this condition consists of uncontrolled attacks of short duration of sleep. These attacks are usually triggered by strong emotions such as laughter or anger. Clients may receive therapy to deal with the stigma of this disorder and the perception that they might be lazy or unmotivated because they are so sleepy during the daytime. But narcolepsy is typically treated with various psychostimulants. They can also be treated with antidepressants, hydroxybutyrate or GHB. Historically, stimulants have been used to reduce daytime sleepiness and sleep attacks, along with antidepressants to increase the sleep quality. If a client were to take GHB, this increases the quality of both REM and non-REM sleep cycles. However, the side effects of GHB include excessive grogginess, mental confusion before the drug wears off. Restless leg syndrome, RLS, or periodic leg movement disorder. These are other sleep disorders that might affect client. With restless leg syndrome usually occurs in the evening and throughout the night. The client complains of feeling restless or jittery and may not be able to relax. They often report that this feeling starts deep within their legs, and they often move or tap their feet to gain relief. Periodic leg movement disorder can cause sleep fragmentations and daytime sleepiness. With this disorder, the legs often jerk every few seconds, and this movement can increase in intensity to the point where sleep is seriously disturbed. Usually with these two sleep disorders, the RLS or the PLMD, benzodiazepines are given to the client. Just as a side note, with restless leg syndrome as well as the periodic leg movement disorder, some researchers have believed that there are certain drugs such as antidepressants may exacerbate these sleep disorders. So that is to take into consideration just when going into thinking about a medication history, and to look at perhaps this could be one of the side effects if the client is on a certain medication, that the side effect could be RLS or PLMD, or the fact that they could just be taking a certain medication for long periods of time, which could lead to the sleep disorder. And as mentioned in previous slides, sometimes they might need to be referred to a sleep specialist to complete a sleep study, or to complete a nocturnal polysomnogram, or NPSG. Behavioral techniques that could be used are relaxation techniques. Biofeedback might be helpful, as well as cognitive behavior therapy or sleep hygiene. While behavioral techniques typically take longer to learn and do not offer immediate relief, they have been shown to have lasting effects that clients can employ long after medication has been discontinued. From a pharmacological and holistic approach, here are some sedative hypnotics commonly used. Benzodiazepines. Benzodiazepines should be used for only about 2 or 3 weeks. It is also important while you're taking the patient's history to check for a history of substance abuse. These medications have been known to increase the risk of cognitive impairment, slip and fall accidents in the elderly. There are a few sedating antidepressants that can be used for clients who have sleep disorders, but these are really good for clients who also have a sleep disorder along with an affective disorder. Barbiturates can cause sedation and have been used to treat insomnia. However, they are not used much today because they have a narrow therapeutic index and a high potential for abuse and may interfere with normal sleep cycles. Melatonin is an endogenous chemical that we produce. The levels of melatonin fall with age and may be further depleted if the client is regularly using aspirin or ibuprofen. So, in various studies, it is found that taking melatonin pills has increased a person's ability to have better quality of sleep. However, too much melatonin might lead to daytime drowsiness, cognitive slowing, and possibly an increase in depression over time. Diphenhydramine, which can be found in Benadryl or other antihistamine hypnotics, as well as over-the-counter sleep aids, may be used to reduce problematic intermittent insomnia. From a holistic approach, we can look at kava. Kava is used by people in the South Pacific for thousands of years. Its actions is similar to a sedative hypnotic because it appears to bind at the GABA receptors. Valerian root can be used as a mild sedative, anxiolytic, and antidepressant. Its actions are really not understood, but since GABA itself is a component of the valerian, scientists and holistic advocates believe that the valerian is a source of naturally occurring GABA.